Good afternoon, everyone. This is Professor Dunham, and I am here to go over the rest of Chapter 14. We did Chapter 13 on the preterm and post-term newborn last Tuesday, and I got halfway into Chapter 14, but we had to cut it short. So I want to pick up where we left off. And then also, I'm going to let you know that I already put a video of chapter 13 and 14 under announcements for you. So you have that. Okay. So I'm going to go ahead and share my screen now. And let's get going here. Got a lot of information for you. And I know you want this information. So here we're going to pick up on the objectives for lesson 14.3. And we're going to talk about Down syndrome. And we're going to talk about erythroblastosis fetalis. And I got phototherapy for jaundice, under jaundice. And then I'm going to talk about increased intracranial pressure. And then, of course, macrosomia. Okay. All righty. I want to make sure you have this information because some of this information could be on exam number 3. All right, so Down syndrome is your most commonly chromosome anomaly, honestly. What happens is it increases with age. So mothers who are 35 years and older can come have it, and fathers even at 55. The sperms get old at age 55. Now, what happens if the child has from mild to moderate some form of retardation, and then some actually have some physical anomalies also. All right, so this is why when we have a woman who is AMA, advanced maternal age, we like to do an amniocentesis in the beginning to let them know if they have the risk, because it lines up the chromosomes so nicely, and it tells you if there's a trisomy, an extra chromosome. Because remember, all the chromosomes have 2, right? They're little pairs. And sometimes as things get old, they don't form as they should, and there's an extra chromosome attached. And so then you have 3, and you have then a Down syndrome baby. Also, another test that can be done to determine is called the alpha-fetoprotein test. That's done between 16 to 18 weeks gestation. But then again, that has a lot of false positives. So if we get an alpha-fetoprotein test that's abnormal, we are going to follow up with an amniocentesis. Okay. So these are tests that are offered. Now, I've had patients that had had positive alpha-fetoprotein tests, and they said, I'm not going to do anything. Some of them don't even go for the alpha-fetoprotein test because they said, no, whatever is there, I'm going to keep. So, all right. And then we have it. This slide just shows you the different types of the phenotypes of the Down syndrome baby. Now, we talked about screening. And again, amniocentesis is your most accurate test. So just write that down. Amniocentesis is most accurate. Okay. And here's a picture. It comes right out of your textbook. What a Down syndrome baby looks like. And they have what we call the Simeon crease that goes right across the palm of their hand, and it is a straight line. So if you look at your palms, you don't see a straight line going across. No. And that's very, very indicative of it. And also a big sign is also a protruding tongue. Okay. So when they come out, they could be limp, flaccid, because they have hypotonia, their muscles very weak. There's no tone to them. They are very prone to respiratory illness and constipation due to the hypotonicity. They have no tone again. And these babies, sometimes they have incidence of acute leukemia is higher, and then they have Alzheimer's disease, more common to those who reach middle age. And Down syndrome babies, so according to severity, but they can do very well in today's world. And there's a lot of classes, a lot of schooling that goes on for them and to help them. Um, we want to always give the parents lots of support and community referrals. So these are just the developmental milestones. And basically, with a Down syndrome baby, they might not follow these all in line like you think, but they can do some. And then you always have to help with eating and toilet training, and of course, dressing. Okay, so that's for the Down syndrome baby. We're going to go into the next perinatal injury is in the blood, and that would be erythroblastosis fetalis. We talked about this in other chapters because you can see how the chapters kind of build on each other. So again, mom is Rh negative and daddy's Rh positive, they produce an Rh positive baby. A lot of times we don't know blood types of babies, so we go with, if mom's Rh negative, she's getting RhoGAM. Okay, that protects not only that pregnancy, but the future pregnancies, because we don't want maternal and fetal blood to mix. They're not supposed to mix during pregnancy, but sometimes there's a leak and things can allow some fetal blood to enter mom's circulatory system and causing here's mom, okay, and causing her body to attack the baby's blood, baby's erythrocytes. She's a big old pack lady. Here she comes, okay? And here's baby's little erythrocytes, and they're just out here very nicely, but mom's producing antibodies that will cross the placenta and eat up these blood cells of the fetus. What happens? Baby becomes anemic, and heart failure in this growing fetus it is very serious. That's why when we found all this out, so easy, and this comes right out of your textbook, but you can see there's a little it's a diaphragmatic schematic here showing that how the cells are going in and out, and there's mixture. Again, we don't like those things to mix, but sometimes it happens. Okay, so what happens too is because she has to get RhoGAM with each pregnancy, is because mom accumulates antibodies with each pregnancy. So the chance of complications can occur with each subsequent pregnancy. So we don't want we want this baby to have hydrops fetalis, progressive hemolysis causing anemia. No. Heart failure, fetal hypoxia. We don't want any of that. So we're going to give her RhoGAM. We give RhoGAM during pregnancy and then RhoGAM after, okay, before she goes home. This shows you a slide that shows you have to get her history. Did she have any topics? Was she previously sensitized? Did she have any abortions? Blood transfusions? Did she have a child in the past who developed jaundice or anemia during a neonatal period? And indirect clues will indicate a previous exposure to Rh positive antigens. Now, confirmed by amniocentesis and monitoring of the bilirubin levels in the amniotic fluid. It's pretty serious when you start doing stuff like this. Our fetal Rh status can be determined invasively via free DNA and maternal plasma. Kind of like to go that route rather than going in with an amniocentesis. And then diagnostic studies will help the physician to determine if early intervention, such as induction of labor or intrauterine fetal transfusion. That's very complicated, and they only do that if they need to, okay? So what are we going to give her? RhoGAM. Now, Hesse likes to use the term RHD immune globulin. Okay, so you might see that on Hesse, and you know that is RhoGAM. Is administered 72 hours after delivery before she goes home. And baby, again, infant's RH positive, gonna get it. Now, mom had an ectopic or an abortion, she's gonna also get it. Anytime that she has pregnancy and she loses it, she's going to get RhoGAM. Again, you're protecting, because each time, remember I said, each time she's building up more and more antibodies. Every time she's pregnant, she accumulates them. So this way, you know, we protect the next pregnancy. Okay. And also we give it during pregnancy. All right. Then there's two tests. I already went over indirect. Now direct Coombs is right on the umbilical cord. Okay. And so, you know, if things, she didn't get RhoGAM and there's a problem, and you have a positive Coombs test, you may have pathological jaundice, which occurs in the first 24 hours of life. Okay. Again, an infant's liver is immature and it cannot break down the increased amount of bilirubin. So what it does, the bilirubin levels then would rise. Okay. Baby's enlargement of his edema of his liver and spleen, and oxygen carrying capacity of the blood is diminished, including blood volume. Remember, you get oxygen through the blood. And so if you have problems and the blood is diminished, you have less oxygen. So that's why the infant's at risk for shock or heart failure. All righty. If bilirubin gets to a toxic level, it can cause kernicterus. Not good. It causes mental problems, including brain damage and permanent disability. Infants can have jaundice along with irritability, lethargic, poor feeders, high pitch, shrill cry, muscle weakness, and then seizures. Okay, now, prompt identification is needed. Laboratory tests are done, drug therapy, phototherapy, especially if you have a baby that's yellow, you need phototherapy, and you have exchange transfusions if indicated, and sometimes it is. Okay, so when you have a baby that's receiving phototherapy for jaundice, this is what you have to make sure. Number one, ensure eyes are protected from phototherapy. Yeah. They're in like a little area. They have these ultraviolet lights coming straight on them, and it makes, you know, you don't want that baby to be looking at these ultraviolet lights, such as you, when you, especially if you live here in Florida, you go out in the sun, you don't look, you can't look directly into the sun without sunglasses. You can't even look directly in the sun, but you can't even go out without sunglasses. The sun is so bright. That's again the same thing with an infant in phototherapy. That's ultraviolet light that's beaming on his body, breaking up the excess bilirubin. Is that you got to cover his eyes. Also, you want to cover the gonads. You have them in maybe an incubator. Sometimes they have an umbilical vein catheter in. Always observe his newborn color, and you want to make sure that, you know, you have a little diaper on them, because you want these babies to urinate and you want them to poop, because when they do so, they're going to get rid of the bilirubin. That's how the body gets rid of the bilirubin. It breaks it down and sends it out of the body. Okay, remember something. Jaundice that occurs on the first day of life is always pathological, and it must have prompt intervention. This baby can get very sick on you and die. So prompt. Okay. All right, and how I look at it, I look at the skin and the whites of their eyes, and you can see like a yellow orange. Also, what I do too, especially over the nose, I blanch the skin over a bony prominence, elbow, and you let it go, and you can see it turn yellow. Okay. All right, here's my little baby. You don't look too happy right now, does he? No. Okay. Because he's has jaundice. So here's a picture of what phototherapy looks like. You can see the ultraviolet lights coming straight on the baby. All the baby has on is like a little diaper, just enough to get the excretions, but that's it. Because you want the ultraviolet light on the skin. You've got to break down that bilirubin. Mm-hmm. And you can see his eyes in here. You can see right here, he's got the covering of his eyes. Yeah. And these babies, I mean, they don't like their eyes covered. So sometimes they'll try to get rid of it. Get this off my eye. So it takes very good nursing care to go back in there and to make sure you cover the eyes. And there's a closer picture, and you can see we do that fishnet netting, and that helps to hold the eye patches in place. Mhm. That was really a blessing when this came out. All right, this is my thought. And then this is a picture of home therapy. Now, they may go home and you can use a Billy light at home. Is less costly, of course, because you're getting out of the hospital. And sometimes if they have just mild to moderate physiological jaundice, which is more we call a normal jaundice, they can go home on Billy lights. And they will have a home health nurse to come out too and to evaluate moms and make sure that all this is going correctly. Because again, we do not want this baby to have the bilirubin to keep what going up. No, not at all. Okay, the next area I'm going to talk about is intracranial hemorrhage. Okay, unfortunately it is a common type of birth injury. It results from trauma or anoxia. Um, Yeah, and even babies that are in mom deliveries, like a precipitous delivery, that can cause intracranial hemorrhage too, because the baby descending very quickly. Okay. Um, Often this occurs in pretermers because again, their skin is so superficial that there's not much up here and can cause and these vessels. Remember we talked in the preterm baby, the vessels are very superficial and they're very fragile, and so those capillaries, so they can get hit. Okay, so we have to be very careful with our preemies. Diagnosis, you can do a CAT scan or an MRI, and what you'll see is some increase in the cerebral spinal fluid pressure, okay, in the head. Um, Treatment, yeah, oxygen, gentle handling of the head. You want to keep the head elevated, and medications may be prescribed. Care with feeding because sucking reflex may be affected. If convulsions occur, you want to notify the physician immediately. So you're going to be watching this infant and be ready to answer the following questions. Well, remember, and this can go for any kind of seizure, really. Were the arms, legs, or face involved? Was it on the right side or the left side of the body? How long did it last? Always time a seizure when it starts and when it ends. And you always want to give what kind of condition the infant was in before and after the seizure, like vital signs and skin color, all that when you give what an SBAR report. Okay. Okay, now we're going to go right into TTN, which is transient tachypnea of the newborn. Okay, so what is it characterized by? Tachypnea. rapid, right? Rapid breathing. And also can have grunting, chest retractions, and mild cyanosis. Um, that could be a really good question for you to see again. So I would take note to that. So again, it's never good. Let me put it this way, in any baby to have chest retractions. You can see the little sternum being retracted, never good. If a baby's making a noise, grunting, ugh, you know, it's a horrible noise. I'm trying to imitate it, but it's pretty hard. But it's just like he can't breathe. And of course, he may have some mild cyanosis, and he might do that around the mouth or the body. It's never good. So it's often referred to as respiratory distress syndrome type 2. Remember, I always said the biggest job this infant has to do when he's born is to breathe. TTN can also resolve itself after 3 days. And what happens, babies are born with a lot of fluid in their body and their lungs after birth. Why? Because they've been swimming in fluid for 9 months. Okay, so they have to get it out. That's why vaginal deliveries are really, really good, because the fluid actually gets what? Squeezed out. Okay. With a C-section, babies are lifted. So they don't get that squeezing motion that you get when you come down the passageway down the vagina. So they could have more fluid in their lungs. So and babies, their absorption is rather slow. So you may see that. And that's why after 3 days, it seems to get better, because they're able to get out the fluid. Okay. All right. So now we're going to go into our babies that had their first bowel movement in utero, and that's called meconium aspiration syndrome. Okay, so we talked about this before, but fetuses that expel the meconium into the amniotic fluid, they have their first bowel movement inside. The first bowel movement is called meconium, is a real thick, tarry substance, and they expel that in utero. Not a good thing. But maybe the baby is under some form of stress or de-stress, and he passed his first stool. Okay. A lot of times when you get a post-term babies that are 42 weeks and above, they can expel their first meconium, and it could be still in utero. Okay, so if asphyxia or acidosis occurs, the fetus may have gasping movements that cause a meconium stain amniotic fluid to be drawn into the lungs. This is the same thing I just said. At delivery now, what we do when we deliver a baby that's meconium stain, the head emerges. We have the wall suctioning all hooked up. And so when the baby's head emerges, doesn't take any kind of breath, provider will go ahead and suction the baby using like a trochanter all the way down, really getting, not all the way down, but in the oral mouth, getting all the meconium that he sees coming out. And it's wall suctioning, so it's good suction. They get as much as they can. Now, when the baby body emerges, okay, the provider does not stimulate this baby. We keep very quiet, and they take the baby over to the radium warmer. They put it under the radium warmer, and then you have already there, ready to go, all set up, respiratory therapy, and then NICUs. They'll go ahead and be ready and suction the baby. Okay. All right. Your symptoms that you might see are respiratory distress, nasal flaring, retractions, cyanosis, some grunting, some rails and rock eye, tachypnea that may persist for several weeks even, okay? So these babies are what we call sick babies. Treatment, you provide warmth, oxygen, support care, and the NICU. Okay, so under treatment, you want to provide warmth, of course. All babies need a nice breathing warmer. Oxygen, and probably going to go to the neonatal ICU for a little while until we know that he's doing better. These babies have a lot of what I call rapid breathing, tachypnea. Remember something, grunting is never good because they're trying to breathe. It's like this. Now I got it. Is making that terrible grunting noise. And then could be blueness, retractions, sternal retractions, never good. Chest retractions, never good. And you can really see their little sternum pulling. Again, you know, they're babies. You can see it easily. And then nasal flaring. Nasal flaring is a sign of respiratory distress. So we don't want that either. Okay. So that's your meconium. And now we're going to go into another problem with infants, could be neonatal abstinence syndrome. Okay. And this is caused by fetal exposure to drugs in utero. So a lot of your illicit drugs, they do cross the placenta barrier, many, many of them. And therefore, an infant born to a woman who's an addict will suffer drug withdrawal after birth. And then infants also may have like long-term development and neurological defects. Yeah, these babies are really sick at birth because they've been used to what? Getting their drug. When they're born, the cord is cut, there's no more drugs. And so they go through withdrawals, just like somebody who's coming off drugs goes through withdrawals. And it's not pretty, even for with babies, it's very sad. They have body tremors, and they're hyper irritable. Okay, that means that they're inconsolable. They can't be consoled. Okay, they're awake, and they have diarrhea and poor feeding and sneezing and yawning. I've seen that on questions, so be for exam number 3. So take note to that. Testing. Meconium may be more accurate than neonatal urine for presence of drugs. They'll take the first meconium and they'll drug testing on it. Okay. Now, how are you going to take care of these babies? Well, got to wrap them up real tight. So we call that swaddling. Put them in, you have to have a quiet environment. They cannot have a lot of stimuli because it makes them what? Jump. Okay, because they're already hyper irritable. And that hyper irritability, write that down. That's a primary sign. Okay. And then we might have to give these babies phenobarbital because we're also worried about seizures. Again. So what's your treatment? It includes providing a quiet environment with some swaddling, reduction of external stimuli, and close observation procedures. And medication would be phenobarbital. Okay, what about a mom that is diabetic? What happens to these babies? Well, these babies, again, there's a large amount of glucose that's transferred to the fetus during the pregnancy. That's why I want to keep mom under control. So when they're in utero, they're in what we call a hyperglycemic environment in utero. Now, because they're getting fed by mom, remember sugar? Remember I told you the story about, kind of equated with giving you a Snicker bars like all day long. And then all of a sudden now I tell you no more Snicker bars. what's going to happen? Your blood sugar goes down so quickly. Boom, it's going to bottom out. Okay, same thing. Because the fetal pancreas can't keep up with everything. Its fetal pancreas is trying to produce enough insulin, right? Insulin comes from the pancreas to what? To handle this high sugar, okay? But it just can't either. So it all leads to what? Hyperinsulin, and you have an excess amount of protein and fatty acids, and they all result in what? A large gestational baby. Oh yeah, these babies weigh anywhere from 8.8, 9 pounds and greater. Okay, these are big babies, over 4,000 grams. So what are we gonna do? Well, after delivery, now when after delivery you cut that cord, baby's not getting sugar anymore. So you put them over, you bring them over to the radium warmer. You kind of assessing the baby, right? Drying the baby off. Make sure he gets nice and dried off. I'm doing the APGAR score. Okay, 1 in 5 minutes, and baby starts maybe having a little, irritability, tremors, and you're going to do a glucose level on him. We do it right there in the labor room, and we do it by what? A simple little heel stick. And or you can take a little bit of blood, but it's quick the other way. And what you're doing is you want to get a fast glucose level on this baby, because this baby probably is going into hypoglycemia. It happens rather quickly. And so I don't want him to have that, because babies that have a hypoglycemia can also have complication with respiratory distress syndrome. Not good. So I want to go ahead and keep this baby from having, I want to be ahead of the game. I want to know exactly what where the blood sugar is, because again, these babies, these symptoms, like I said, body tremors. Here, sorry about that. They have, they can have even like a moon face. That's called a cushion gold appearance. It looks like a real round face, like a moon face. Yeah, moon face, because excess amount of fat builds up on the sides of the face. Okay. Yeah, I know you know about Cushing syndrome. That's where Cushingoid appearance looks like, is because of the term Cushing syndrome. Okay. All right. And the baby can suffer from hypocalcemia, low calcium, and then could have hyperbilirubinemia, because again, the amount of circulating blood going on in this amount of bilirubin being going up high. So these babies, so I want to know right away what we're going on with these babies. Okay. And here it is. Here's what you're looking for. That's what I was looking for before. You're going to monitor glucose levels, vital signs, signs of irritability, tremors I talked about, and respiratory distress I talked about. Now, some books say 45, some books say 40, but a glucose level below 40 can also cause pretty rapid and permanent brain damage. So do I want hypoglycemia in my baby? No. And that's why we actually test all babies. Alrighty, well, that's the end of this chapter. That was chapter 14. And I have already put a little video already under your announcements that I did last semester on chapter 13 and 14. So be sure to look at it, take the time, and then be sure to attend the exam reviews that we have for you tomorrow. Okay, have a good evening, everybody.